Let's see about diabetes in pregnancy. As we all know, diabetes is the most common medical complication in pregnancy. First, let's see the classification of diabetes in pregnancy. Basically, the diabetes in pregnancy can be classified as overt or pre-gestational diabetes and gestational diabetes mellitus. So, the overt or the pre-gestational diabetes mellitus means the pregnant woman was diabetic before the onset of pregnancy. This can either be type 1 or type 2. Whereas the gestational diabetes mellitus is defined as carbohydrate intolerance of variable severity with onset or first recognition during the current pregnancy. This is the definition for gestational diabetes mellitus. Carbohydrate intolerance of variable severity with onset or first recognition during the present pregnancy. So, this is the classification. Now, coming to the effect of pregnancy on diabetes. As we all know, pregnancy is itself a diabetogenic state. So, the pregnancy is itself a diabetogenic state. The factors which are responsible for this include the human placental lactogen and the steroids like cortisol, and also the progesterone. All these hormonal levels get increased during pregnancy, which have an insulin antagonizing action. So, they in turn lead to diabetogenic state during pregnancy. And also the placenta secretes an enzyme called insulinase, which is responsible for the degradation of insulin. This in turn adds on to the diabetogenic state. Now, let us see the effect of diabetes on pregnancy. Firstly, the gestational diabetes mellitus has a significant risk of stillbirths, macrosomia, that is a big baby. Next, there can be neonatal hypoglycemia, or hypocalcemia. Also, there is increased risk of thrombosis, especially the renal vein thrombosis. Overall, these are the important risks in gestational diabetes mellitus. Let us see all the other risks one by one. First is abortion. There is an increased risk of abortion in patients with especially uncontrolled gestational diabetes mellitus. Next, there can be preterm delivery. Especially seen with overt diabetes mellitus or pre-gestational diabetes mellitus. Next, coming to the fetal factors, in the fetus there can be malformations which include neural tube defects, cardiac anomalies like atrial septal defect, ventricular septal defect and transposition of great arteries, and specific anomaly to gestational diabetes mellitus is the caudal regression. Also there can be sacral agenesis. And in fetus there can also be unexplained fetal death. Coming to the pregnancy complications, as we have already seen, there can be abortions, there can be preterm labor, and there can be polyhydramnios. This polyhydramnios can be due to the large placenta or the fetal malformations, or this can also be due to the fetal polyuria, which is secondary to fetal hyperglycemia. So, the maternal hyperglycemia gets transferred to the fetus, leading to fetal hypoxia, secondary to which there can be fetal polyuria, which is one of the symptoms of diabetes mellitus, which presents in the mother as polyhydramnios. Next, there can also be shoulder dystocia. This is because there is excessive fat deposition in the fetus, especially in the shoulders and the trunk. So, during delivery there can be shoulder dystocia. And also in the mother there can be pregnancy induced hypertension. This is an important feature seen associated with gestational diabetes mellitus, and there can also be maternal infections, because diabetes, as we all know, is an immunosuppressed state. So, the mother is more prone for developing infections. These are all the effects of diabetes on pregnancy. Now, coming to the diagnosis. Diagnosis of gestational diabetes mellitus. Nowadays, both screening and for diagnostic purpose, only one test is performed, which is oral glucose challenge test. OGCT stands for oral glucose challenge test. So, this test is recommended as both screening and diagnostic test. Now, let us see about the OGCT. First, how is this test performed? Here, 75 grams of glucose is given mixed with 300 ml of water, and the patient, that is the antenatal mother, is asked to consume this over a period of 5 minutes, and this is given irrespective of her last meal. And then The venous blood sample is collected and the plasma glucose is estimated after 2 hours. If the value is more than 140 milligram per deciliter, then she is considered as having gestational diabetes mellitus, whereas if it is less than 140 milligram per deciliter, then it is normal. So, this is the oral glucose challenge test. And now there comes a question, when to do this test. For this the answer is, this is done 3 times. The first time is when the antenatal woman comes for the first antenatal visit, or between 12 to 16 weeks of gestation. Second time the OGCT is repeated in 24 to 28 weeks, even if the first test comes out to be normal. And then the third time the OGCT is repeated in 32 to 34 weeks of gestation, irrespective of the test, initial test being normal or abnormal. So, the women who are tested normal at 12 to 16 weeks should also undergo repeat OGCT at 24 to 28 weeks, and even if they are normal at 24 to 28 weeks, they should be taken OGCT at 32 to 34 weeks. So, these 3 are mandatory for every antenatal women. Coming to the management, our aim is to maintain 2-hour postprandial plasma glucose level in the range of 110 to 120 milligram per deciliter. So, to maintain the 2 hours postprandial plasma glucose level within 110 to 120 milligrams per deciliter. For this, we can follow many treatment methods. The basic is the meal plan, which is also called as medical nutrition therapy, referred to as MNT. So, in the initial stages, the women after being diagnosed to have gestational diabetes mellitus should follow the medical nutrition therapy for 2 weeks. This is nothing but the woman is asked to distribute her calorie consumption over the day instead of having everything together. So, this includes splitting the breakfast into 2 halves and eating the breakfast with a gap of 2 hours in between. So, in this meal plan, she should avoid sugars, sweets, etc., and avoid fasting as well as feasting. And then more green leafy vegetables should be added to the diet. So, after following the medical nutrition therapy for 2 weeks, then the 2-hour postprandial plasma glucose levels are taken, preferably after the breakfast. If the postprandial blood glucose comes under 120 milligram per deciliter, then the meal plan can itself be followed the medical nutrition therapy is still continued, and the repeat 2-hour postprandial glucose levels should be taken after every 4 weeks until delivery. And also, the antenatal women who was diagnosed to have gestational diabetes mellitus should be advised for moderate exercise of at least 30 minutes per day. And if the blood glucose is not controlled by the medical nutrition therapy, then we give insulin. So, initially the intermediate acting insulin is given, and then after 2 weeks again the postprandial plasma glucose level is checked, and if it is within 120 milligram per deciliter, we continue the same dose. If the values further increase, then we also increase the dose of insulin according to the plasma glucose levels. Next, coming to the obstetric management. In the obstetric management, first we perform thyroid function tests and HbA1c levels. A HbA1c of 5 to 6% is desirable. If it is more than 9.5%, there is very high chance of congenital malformations in the fetus. Next, we perform a nuchal translucency scan at 11 to 14 weeks. Next, we see retinal assessment at first visit, then at 28 weeks for any retinopathy which can be associated with diabetes mellitus. Also, we do renal assessment at the first visit to check for nephropathy. And then we do ultrasound to detect any anomalies. Then, if the facilities are available, we perform the serum alpha fetoprotein levels at around 16 to 20 weeks of gestation to see for any neural tube defects in the fetus. And also we can do a fetal echocardiogram to detect any cardiac anomaly in fetus. Then we should advise for regular antenatal checkups, which should be once in 2 weeks till 32 weeks, and thereafter once weekly until delivery. And we should hospitalize the patient whenever there is poor control or there are any complications of diabetes. And then the most important thing is antepartum surveillance, which includes non-stress test, biophysical profile, etc. This should be started at around 32 weeks in all the cases of diabetes mellitus. And the timing of delivery depends on the fetal well-being. If the diabetes is well controlled, then we can leave it till term. In overt diabetes, termination is considered at 37 to 38 weeks if the fetus is not under stress. And in all other situations, the termination of pregnancy is determined by the fetal well-being. Then after delivery, the women who was diagnosed to have gestational diabetes mellitus should undergo the oral glucose tolerance test between 6 to 12 weeks postpartum. This is postpartum testing for mothers with gestational diabetes mellitus. If it comes out to be normal, then the Ogtt to be repeated at 6 months and thereafter every year after delivery. So this is about the postpartum testing in mothers with gestational diabetes mellitus. So these are all the important points in diabetes complicating pregnancy. Thank you.